Hello, my name's Dr. Stephen Pipe. I'm a professor of pediatrics and pathology at University of Michigan. So, hemophilia B is an inherited bleeding disorder where patients are missing clotting factor 9. This is a critical blood clotting protein. And the patients with a severe deficiency of this are at risk for traumatic and spontaneous bleeds, primarily into their joints. And with repeated bleeding into their joints, this can lead to inflammatory and degenerative changes in the joints that eventually leads to a debilitating arthropathy that can really be crippling and impacts on their quality of life. So to try to prevent this, patients beginning as young as infants are placed on regular IV infusions of clotting factor 9 concentrates. Now, because of the short half-life of these concentrates, the patients have to infuse on average once or twice a week. Um, the prophylaxis has to be really continued lifelong in order to prevent bleeding events and protect joint health over the lifespan. And so this is a tremendous burden on the patient and their caregivers. And we know even with regular prophylaxis that joint bleeds can still occur and arthropathy can still ensue. So we think this is because the blood levels often reach critically low levels just before the next IV infusion. So the challenge that gene therapy aims to overcome here is by delivering a functional copy of the factor 9 gene into the patient's own liver, we would allow the patient's liver to make a continuous supply of factor 9 that would be delivered in the bloodstream. And then this would lead to a steady state expression of factor 9 with levels that we hope would be or even within the normal range, and then patients would no longer be subject to bleeding events and they would not require prophylaxis any longer. So the real hope from gene therapy is that a one-time treatment would produce a durable and functionally curative persistent levels of factor 9 in the plasma. The idea of gene therapy research is to develop a one-time treatment that can lead to steady-state expression of the clotting factors in the blood. So to do this, we use a adeno-associated virus vector as the delivery vehicle for a functional copy of the factor 9 gene. So we call this the transgene. The vectors naturally home to the liver. The particles get taken up by the individual hepatocytes. The vector then delivers this functional copy of the factor 9 gene to the nucleus of the cell. And there, the transgene forms circular DNA elements that we call episomes. And they persist in the cell, and they use the normal machinery from the hepatocyte to start to synthesize the factor 9 protein. And the cell then secretes that factor 9 into the blood plasma, and it reaches up to a steady state level, and that's what's going to produce the lasting effect for the patient. The gene therapy etranacogene dezaparvovec uses a adeno-associated virus serotype 5 as the delivery vehicle vector, and it contains a factor 9 transgene that is the uh, that is the functional. Sorry, I'm going to start this again. Okay, one more time. Etranacogene dezaparvovec uses an adeno-associated virus vector, serotype 5, that's had the viral genes replaced with a functional copy of the human factor 9 gene. And this transgene has actually been enhanced by a naturally occurring point mutation that codes for a hyperactive form of factor 9. This is called the Padua variant, Padua. And this boosts the effective activity of factor 9 in the blood plasma by about 6 to 8 fold over natural factor 9. So this vector is delivered as a single IV infusion in the outpatient setting. And what we see within a couple of weeks is that the factor 9 expression is sufficient to protect patients from bleeding. The subjects in this trial, we've actually seen achieve a mean factor 9 activity of 37% at 26 weeks following dosing. And the non-hemophilic range starts just at about 40%. These levels have remained stable over the course of the study, and the longest follow-up period now has been 18 months. So these levels have allowed the patients who achieved transduction to cease prophylaxis for the duration of the follow-up period, and the number of treated bleeds fell by 91% compared to a 6-month lead-in period when all the patients were on their regular prophylactic factor IX infusions. There are two additional takeaways from this trial that I think are important. So first of all, this study is the first phase 3 study to report findings on their entire cohort of subjects getting gene therapy for hemophilia. And it's also the largest cohort of subjects who have received gene therapy for hemophilia to report to date. The other thing is that all AAV5 mediated liver direct gene therapy trials to date have excluded patients who had pre-existing neutralizing antibodies to the AAV5 vector. Now, these antibodies appear presumably exposure over the course of the life to adeno-associated viruses in the wild. However, we had preceding phase 1 and 2 studies that suggested that pre-existing antibodies to this AV5 would not impact transduction. So although all the subjects in this trial were tested, they received the dose anyways. Over 42% of the subjects had pre-existing neutralizing antibodies, and these had no correlation with any safety or efficacy parameters. The results actually show that we saw effective transduction in patients who had antibody titers as high as 678. So these are encouraging results because the ability to treat in the presence of these pre-existing antibodies is going to maximize eligibility for patients. So the core defect in hemophilia is ineffective clot formation due to insufficient thrombin generation. And fitusiran is a small interfering RNA that's designed to lower antithrombin to then improve thrombin generation and promote hemostasis in people who have hemophilia A or B with or without inhibitors to factor VIII or factor IX. In a completed phase 1 study, monthly subcutaneous administration of fitusiran was generally well tolerated. It lowered antithrombin in a dose-dependent manner, and this resulted in increased thrombin generation and decreased bleeding frequency. So the safety, tolerability, pharmacokinetics, and pharmacodynamics, as well as dosage setting, was explored in that phase 1 program. But then a phase 2 open label extension study was designed to evaluate the long-term efficacy and safety of fitusiran. This included adult subjects with moderate or severe hemophilia A or B with or without inhibitors. And they were on continued monthly subcutaneous prophylactic dosing at 2 doses of fitusiran. We've had a total of 34 subjects now who've been followed for a median of 3.1 years on fitusiran dosing, but actually a maximum of 5 years. And it includes participants from all the eligible groups, hemophilia A, B, with and without inhibitors. What we see is that antithrombin lowering occurs quickly upon dosing, and they reach a nadir beyond 2 weeks post-dose, where this is sustained at levels that are at or below 20%. As long as they remain on the monthly subcutaneous prophylaxis. And then accordingly, the thrombin generation in these individuals is approaching overlapping with normal individuals. So not surprisingly, the subjects have achieved overall median annualized bleed rates that are essentially zero for treated bleeds during the observation period. And this was similar for hemophilia A or B, and also similar with or without inhibitors. We did analyze the treated bleeds that patients had over the course of the observation period. And in general, any breakthrough bleeds were mostly located in joints. They were mild in severity, and they tended to be more spontaneous in those patients with inhibitors. Now, what's interesting in this study is fitusiran improves the thrombin generation, but it doesn't treat a patient if the patient had a breakthrough bleed for some reason. So the breakthrough bleeds still have to be managed with factor replacement therapy or bypassing agents if they have an inhibitor. And because of the substantially improved thrombin generation, we have to instruct the patients to use modified breakthrough bleed management guidelines that substantially reduces the dose of factor replacement or bypassing agents, so that they can avoid complications from excessive clotting. Overall, the safety of the patients in the trial uh, has been evaluated, and the most common adverse events were elevations in the liver transaminases, and then headache, as well as injection site erythema. There has been some reported serious adverse events with this therapy, however. There was an individual who had an atrial thrombosis, and also one death that occurred back in 2017. This was due to a cerebral sinus venous thrombosis. Initially, this diagnosed as a subarachnoid hemorrhage, and the patient was getting a lot of procoagulant treatment for that, but then it was subsequently determined that the patient actually had a clot. So it was actually that case that triggered the revised breakthrough bleeding management guidelines that patients have followed since then. So overall, fitusiran is an investigational siRNA therapeutic. It has the potential to be used as a prophylactic treatment for people with hemophilia A or B with or without inhibitors. And this monthly fitusiran prophylaxis provides sustained antithrombin lowering in people with hem A and B with or without inhibitors. It results in a low annualized bleeding rate. The patients have now been followed over a maximum of 5 years. And breakthrough bleeds were generally mild in severity, and were managed in accordance with the revised bleed management guidelines. So fitusiran now is being evaluated in the ongoing global phase 3 ATLAS program.